Welcome to the Dr. Berkson's Best Health Radio Show. And today we have a show that I've been getting a lot of emails from the men around the globe who are saying enough with the hormones only about women. Let's really chat and find out and separate fact from fiction about hormones for men. So today's show is called MAN-opause, which was coined by our guest, Dr. Jack Monaco, who is an integrative medical specialist. And Jack is from the lovely town of Nashville that's kind of like a smaller version of Austin. And he, so to speak, except they sell a lot of Putin statues in the gift shops down there. I don't see any of that in Austin over here. And Jack works at the Nashville Hormone and Integrative Medicine Clinic, and you're going to hear a lot about that clinic, how to contact him at the end of the show, because he's one of the cutting-edge physicians in bioidentical hormones and how hormones play a role in health and how to keep your hormones healthy as you age. And we met when we were both lecturing on hormones at higher board certification courses at the PCCA Institute, which is the institute that supplies all of the bases and the learning courses for compounding pharmacists and medical doctors. So what he specializes in, we're going to bring him on in just a few minutes, is bioidentical hormones, weight loss, how to reduce your need for medicine, the health of women, the health of men. And what we're talking about today is hormones in men. He is a regular MD. He's a doctor that specialized in OBGYN, and then he went on further to become a fellow with the American Academy of Anti-Aging and Regenerative Medicine, which is really the application of hormones. And men kind of miss out on that because women have been getting the memo and reading the books and inquiring and getting bioidentical hormone replacement. And by the way, Dr. Jack Monaco has also been awarded multiple prestigious awards. We're not even going to go through all of them because that would take up most of our show time. He was also won the Connecticut Top Doctor Award, which is really a big deal, an Excellence in Clinical Training Award. So we're really excited to have you back on the show to talk about MAN-opause. Welcome, Dr. Jack.
Thank you, Lindsay. Nice to be here again.
And you're able to give this show because your lovely wife, Lisa, is actually visiting here in the state of Texas where I am while we're talking to you in Nashville.
She's on her way back to Nashville as we speak, so she'll be here probably around 1 or 2 this morning.
So one of the reasons we want to talk about hormones is that there is an epidemic. The NIRI, the National Institute for Research in New England, has documented that younger men have less testosterone, often the levels that their grandfathers used to have. And yet testosterone really protects against heart disease, dementia, type 2 diabetes, etc. So can you talk to me about how we chat with guys, letting them know they need to know where their hormones are at?
Sure. You're absolutely right. I'm seeing younger and younger men with low testosterone. And most of these guys are coming in, some of them because of erectile and libido issues, but a lot of them are coming in because they're tired. They're very fatigued. Their exercise tolerance at the gym has gone down. They can't build muscle. In fact, they're starting to lose muscle. They're starting to gain weight. But their main symptom is fatigue. And I think we're going to be seeing an association, and we already are seeing an association, when these really young guys, late 20s, early 30s, come in with low T, that they are probably developing early changes of cardiovascular disease. So these are the guys that I worry about. These are the guys that I start screening early on to see if they have early changes in the arteries, plaquing, look at their heart, look at their carotids and things like that, and get a baseline for them.
Do you think one of the reasons that insufficient levels of testosterone show up as fatigue first is that we're learning now that testosterone and estrogen for ladies protects mitochondria, which are the energy-producing organelles in the cell?
Absolutely. And I think there's a lot of, estrogen disruptors and receptor disruptors that affect a lot of toxins in our food, a lot of other hormones in the foods, a lot of pesticides and processing in our foods. I think it all affects the receptors. And I said, I think on your last show, that the key to all of this hormone therapies is the receptor. It really doesn't matter what kind of hormone you take, what kind of balance you have, what levels you have, if that hormone cannot stimulate the receptor. And really the receptor is the key. So you have to look at receptor response and receptor blockade. Too much hormone will shut down the receptors, and that very often happens when guys go to their family doctor or the urologist, and he gives them a prescription for topical testosterone, and they just start slathering this stuff on, and they get a response early on, and then the response goes away. So the doctor keeps upping the dose, and all he's doing is just down-regulating the receptors even more. And then there are things like cortisol and stress that will block those receptors. Estrogen will block those receptors. Estrogen raises binding for testosterone that actually effectively lowers their testosterone. So even though their total may be normal, the free and bioavailable, we can talk about that. Free and bioavailable, that's the active hormone, that actually goes down. So they're testosterone deficient, even though their total testosterone may be in the normal range.
So I just want to give a little bit of hormone 101. So hormones deliver a signal to proteins in the shape of a satellite dish. They're proteins that are like a little satellite dish waiting for hormone to come and deliver its signal. That satellite dish set of proteins is called a receptor. Receptor functionality, how well it can receive the signal and send it to your genes, is everything. Yet nowhere in science do we really have testing, or is it taught in medical school to urologists, endocrinologists, gynecologists about the concept of receptor physiology. You just run blood tests. And if your blood tests are within normal range, that doesn't tell you about receptor physiology. So how do you figure out if somebody, so the rubber meets the road with hormones at the receptor functionality. How do you as a doc figure out if somebody's got receptor dysfunctionality?
Well, you see, that's the challenge. There really is no test of receptor function. So really what you have to do is you have to sit down and listen to the patient, tell you what their symptoms are, and tell you what's changed after you started them on hormones. That'll give you a clue. And you just have to be cognizant of all the things that might affect that receptor. So very often we'll send our patients for nutritional counseling to clean up their diet. We'll put them on mitochondrial resuscitation type nutrients. We'll address
I like that, mitochondria resuscitation. So nutrients that make your energy factories alive again, that resuscitate them so that you can have more energy. I like that.
Sure. Then we will also do address the adrenals. We'll look at their estrogen levels and give them things to lower estrogen. Sometimes we have to look at their liver. Sometimes, their SHBG, their sex hormone binding globulin, which binds testosterone so tightly that it's essentially out of the equation. That goes up with age, and estrogen also raises SHBG. So we have to address all of these things.
So what are your tricks, by the way, if you go, see, this is it, if you go to a doctor to get your hormones tended to, they have to have a concept of this bigger picture of all these factors that Dr. Jack is talking about. And for some reason, that's not the way many docs today practice it. There is something in your blood called sex hormone binding globulin, and if it's too elevated, it binds up your testosterone no matter what you have. So if that's high, you're in trouble because you're not getting your T signals. So how do you lower that?
Well, there's a lot of ways. You normalize thyroid function. You give them vitamin D, DHEA. We check their liver enzymes, make sure that they don't have, elevated liver enzymes, cult hepatitis, alcoholic cirrhosis. We'll give them things to lower estrogen, which can raise SHBG, make sure that they're getting adequate protein, a lot of times over-exercising, training for a marathon, or the big mutta, or any of those.
I got a little trick.
Yeah.
Got a little trick.
Yeah.
So, that is a big problem. A lot of people go and get hormone replacement and don't really feel any different. And that's because they've got elevated sex hormone binding globulin that's binding all of that hormone up. So there's a study that came out showing that you could lower sex hormone binding globulin with boron and especially added to fiber. So I give 9 milligrams, comes in 3 milligram tablets. I give 3 of those at one time at dinner. That's 9 milligrams, along with some extra fiber before bed. And as long as you lower the stress, because stress or in any lifestyle issue like you were just referring to, excessive exercise, you just fix all the other factors. It tends to, within about 2 months, normalize the sex hormone binding globulin. It's a trick that I found geek-like sleuthing through the literature.
That's it. We actually give them zinc too, which helps. Boron, 9 grams of boron. That's a nice pearl. Thank you.
I love that. I love when you're talking to somebody and I'm sitting down here writing some of what he's got to say. He's sitting down writing what I do, and hopefully you get in on these conversations where we're learning from each other and we get to share this with you.
Well, it's interesting. This made me the missing link for me, because I've got a couple of guys that I've done everything that I can think of to lower their SHBG.
Which stands for sex hormone binding globulin.
Right. Maybe this is the missing link for those guys. I'm going to try this on these guys.
Okay. You can't have people on it for excessive periods of time because it will slowly start to lower cortisol and other hormones. But so it's just usually for about up to 3 to 4 months with pre and post testing of the sex hormone binding globulin. But, this is really the deal, is that hormones have this complex, bigger picture. But they rule so many things. Like if a guy, testosterone in a man protects his heart cells from early death. It protects blood clots. It protects the size of his hippocampus so he doesn't get dementia. It protects so many different things in a man. And I didn't remind you to turn off your phone, did I? I didn't.
No,
do
you
that.
didn't.
Okay. It protects, as we just said, the mitochondria. It protects the liver against fatty liver. It protects against type 2 diabetes. And, as more and more men and women are sitting all day in their cubicles and in front of their computers, that damages and lowers estrogen in women and testosterone in men. So there's so many protective things hormones do, but we think of hormones as just sexy and reproductive things.
That's right. Well, one of the titles of one of my talks is Testosterone, More Than a Sex Hormone. So we talk about these things, helping with cholesterol, helping to normalize carbohydrate metabolism in diabetic men, reducing their need for their dose of insulin or their dose of medications. So there's so many other benefits. And I think if you just really look at testosterone as only a sex hormone, you're going to miss out on a lot of benefits of testosterone.
So how come when somebody's seeing a diabetologist endocrinologist for type 2 diabetes, this never enters the picture?
Because we're not taught that. We're not taught that in conventional training.
So why is standard of care just dependent on what you are taught in training when there is so much more? So exasperating.
Well, see, the problem is, like a friend of mine says, the mind is like a parachute. It only works when it's open. So the doctors get so bogged down in what they have to do, and there's been such a negative cloud placed over integrative medicine. You'll hear doctors say there's no evidence, it's dangerous, it's expensive, there's no proof, it's not FDA approved. They'll give you all the negatives about it without even knowing anything about it. Or if they have one patient that had a small reaction to something that you're doing, they'll say, "See, I told you." But how many times do they prescribe a prescription drug that's FDA approved, that's mainstream Western medicine, and they have a problem or a death? But it's not. That's just an isolated incident. That's not. You can't throw the baby out with the bathwater, and that's what they're doing, which is really unfortunate. So I'm always thrilled when I see a gynecologist or an endocrinologist in the audience, because that means that they're open-minded and they're willing to learn. I do get very nervous when I see a lawyer in the audience, so I usually stop the conversation right then and say, "Well, we'll take this up tomorrow" or something.
I was just talking with a oncologist that I had referred a patient to that wanted to get off an aromatase inhibitor, and melatonin acts like an aromatase inhibitor, and he's supposed to be a functionally oriented oncologist, and he did not recommend the melatonin. I called him up afterward, after the patient was out of the room, and I said, "How come melatonin acts as well and with many other mechanisms of helping a cancer patient? How come you didn't recommend that?" And he said, "Well, I didn't want to pay for the pool of the lawyer." You want
Oh,
to pay
wow.
for that backyard pool. And so how much
Yeah.
do patients miss out on some really great clinical pearls that would be helpful, because the litigious atmosphere makes it understandably nervous
Yeah.
for the person to deliver some of that care. So how do you get to be so brave?
Well, it's probably a little bit of my heritage and a little bit of being from New Jersey. We never seem to run from a challenge. So a lot of the stuff that I was doing in my practice over the years, I was doing everything that I was taught to do, or so I thought. And when patients didn't get better, I got very frustrated. And I said, "There's got to be a better way. What I'm doing, what I was taught to do, is not working." And then it was actually a patient that turned me on to all of this stuff. So when I teach, I tell people it makes sense. If what you're doing doesn't make sense, why are you doing it? Just because there's a protocol, or because this is what you were taught to do, or this is because what your attending told you to do, or the chief resident told you to do, you got to start thinking. And I was thrilled when I went back to my medical school reunion. I'm not going to mention how many years I've been out of medical school, but the new dean of the medical school, and I went to Wake Forest University School of Medicine, which, by the way, is one of the top 3 most applied to medical schools in the country. And she said, doctors have got to start thinking again. And I said to my wife, I said, I've been saying this for years. I said, I'm so happy.
Patients don't realize that their doctor has stopped thinking.
I know, but I was so thrilled to hear her say that, because that's the type of education that they're fostering at Wake. And I think it's starting to catch on. It's very slow. If we could get rid of our taxes as quickly as we could bring on, the tax, it would be nice. If we could make doctors start thinking more quickly, it's going to take years and years and years, but at least we're making headway, one patient at a time.
Well, it's so odd, because you have to be really smart to make it into med school and take all those tests. And you have to be really brilliant and have a lot of endurance to make it through all those years. And then when you graduate, you're run by pharmaceutical and insurance-driven algorithms that don't promote you to think. And then we all get into a place where the doctor is burnt out, the patient is burnt out. And that's why it's exciting to be doing things like this and having this radio show like this. But if you have men sitting out there right now, or wives of men, or girlfriends of men, or a sister of a brother, and they're wondering whether their brother should be tested. But it's not just testing testosterone. It's not like testosterone exists in a vacuum. And yet, and there's so many data, like this one study that was a complete clinical review, endogenous testosterone mortality in men, a systemic review and meta-analysis. It was Department of Epidemiology from the New England Research Institute again, and it just came out in 2011. It shows if your testosterone levels aren't optimal for you, you die earlier from all-cause mortality.
That's right.
How would you, but then they might run to a low T center or to their own doc who only just runs testosterone. And if it's within normal range, even if it's 300 or 280 or 400, they say you're fine. Why don't you give us the lay of the land of the truth of what is the normal range, and why do you need to test for more hormones, not just testosterone alone, and look at the bigger picture?
Well, you brought up an interesting point, because I tell my guys that all-cause mortality is associated with low testosterone. So we know that there's a benefit to it. The problem is either it's their wives that get them to come in, or they're just so frustrated. And every once in a while, I'll see a guy whose primary care doctor says, "I think you have low testosterone. Go see somebody." And if they're fortunate, they'll in their area, they'll find a doc like me that understands this. But basically, we run a panel of tests on the guys. So we'll do total testosterone. We'll do free and bioavailable, and I'll explain those in a second. We do albumin and sex hormone binding globulin. So I want you to think about total testosterone.
You also do estrogen too, though, right?
Well, yeah. I'll get to that.
Okay.
So let's just go with the testosterone.
Great.
So think of testosterone like the gasoline in your gas tank, okay? You have to have a certain amount of that has to be octane. If you have a lot of lead and a lot of water and a lot of other things in there, it just dilutes out the effect. So the total testosterone is really kind of a meaningless number. But that's what we go by. And the normal range in the laboratory is between 250 and 1100. Okay. Now, I've heard patients tell me that my doctor said my testosterone is low, but not low enough to treat. meaning that it's in the 250, 300, 350 range, but the guy's very symptomatic. So why is he symptomatic? Well, these hormones are fat soluble. They're carried on carrier protein. So you can't have fat coursing through your bloodstream, which is water-based, because it'll clog things up. So sex hormone binding globulin is the major binder for testosterone.
It's the Uber. It's
That's
the
right.
T-Uber.
It's the binder on steroids, okay? Now, the problem, sex hormone binding globulin has such a high affinity for testosterone that once it binds it, it will not let it go.
It's Uber with locked doors that won't let you out at your receptor.
It's essentially irreversibly bound. Now, in most men, in their middle age, about 60% of the total is bound to sex hormone binding globulin. There's another protein that carries the testosterone more loosely bound. Albumin is the major one. Okay, now albumin doesn't bind it so tightly so that when it gets to the receptor, the albumin and testosterone can separate. The testosterone can then bind that satellite receptor that Dr. Berkson mentioned and stimulate the cell to give you the effect of testosterone. That's called bioavailable. That means that the testosterone is available to do its biologic function, the function in the body that it was designed to do. That comprises about 38% of the total. And then about 2% is free, unbound. So when we measure testosterone, we measure free and bioavailable as well as these other proteins. But we also have to measure estrogen. So we measure 2 estrogens. There are 3 human estrogens, but we measure only 2 of them in men. We measure estrone and estradiol, E1 and E2. The third estrogen is estriol, which is the dominant estrogen during pregnancy. So it's not really a big player in men, and estriol doesn't convert to the other estrogen. So the amount of estriol in a man is minimal. Minuscule.
I'm just going to have to add something here, a little footnote. Is that okay? Because you're on a roll. Is that all right?
Right.
So estriol is really important, it turns out, in both genders to reduce inflammation in the gut wall, and it upregulates adhesive proteins to keep the gut wall from getting leaky. It upregulates in specific junctional adhesive molecule A, JAM-A, like a little piece of jam that sticks the gut wall's epithelial cells together. So Jonathan and I now have been given men estriol face cream and giving some estriol to some guys that have these pro-inflammatory or other things. So we have been using estriol. In fact, the talk I'm going to give in Nashville when I come visit with you at the end of next month when I'm lecturing at 8-4M is going to be showing the application of estriol in both genders. So I just had to say a little footnote on that since I've been working on those slides at home.
That's right. But for the purposes of testosterone restoration, estriol is not a major player. So we measure estrone and estradiol. Now, estrone and estradiol, particularly the estradiol, can increase sex hormone binding globulin and can affect receptor response. Now, what happens to a guy as he gets older? He starts getting a little bit more of a belly. That's harbors estrogen, particularly estradiol. What does estradiol do? It shuts down the pituitary stimulation to the testes, so FSH and LH. Those are the 2 signals from the brain, from the master gland called the pituitary gland, that stimulates the testes to make sperm and testosterone. So part of the reason that a guy's testosterone may go down is because of rising levels of estrogen. So estrogen not only binds up the available testosterone, it may also shut down some of the pituitary function, so you get less stimulation of the testes. And we can use that clinically to decide how to raise a guy's testosterone, either giving him testosterone or give him something that will stimulate his pituitary to make more FSH and LH, which will then tell the testes to make more testosterone.
What would that be?
Clomiphene.
Okay.
We give them Clomid, which tells the pituitary gland. We have to measure their FSH and LH, which is another test that we do. So when we do our testing on men, we're measuring FSH and LH. And if the LH is below 3, generally speaking, that man is a candidate or has the option of choosing clomiphene to raise his testosterone. If it's greater than 5, there's a likelihood that it's not going to work, but it's not 100%. And if they're between 3 and 5, it's a coin toss. And quite honestly, if I have guys that have LHs up as high as 6, I'll still give them the option. I had a 77-year-old man whose testosterone in his blood was, I think, 275 or 300, and his LH was on the low side. So I gave him that option. He took minimal doses of clomiphene, just a half a tablet 3 times a week. And in 4 weeks, when I tested him again, his total testosterone was 900. And his free and bioavailable were now in the mid-range. So this guy had the testosterone levels of a healthy 35-year-old after minimal doses of clomiphene. So
now, do most urologists and endocrinologists don't know all this. Where and how does a physician like you get trained in this? This is so critical for treating hormones healthfully, safely, and accurately.
You go to conferences like the kind you see at PCCA or at the Institute for Functional Medicine or the American Academy of Anti-Aging Medicine. And that's really where you're learning these things. I don't know if I would say that they don't know about it. It may be more that they don't care about it, that they just measure total testosterone, because I will tell you that when you start doing this kind of medicine, it requires that you spend much more time with the patient explaining things to them. And if the doctors are seeing 40 or 45 patients a day, there's no time. Okay, so you have to decide what kind of medicine you're going to practice and how you're going to do it.
So as a patient, when you're looking for a doctor, if they're not in Nashville and they can't come see you, when you're looking for a doctor, you want to see a doctor that's been somewhat board certified or gone to courses from PCCA, their acronyms A4M, IFM, and you want to ask the front office how much time usually is an intake take, and how does he or she run their practice, and these make a difference for you to get the better hormonal care.
It does. It makes a huge difference. And patients that call our office, I often hear my medical receptionist saying, well, the first consultation is between 45 and 60 minutes, and then the follow-up consultations are between 30 and 40 minutes. So the patients know that we're going to be spending the time with them. And you really have to make this work.
So what happens if a man has a lot of elevated, a man needs estrogen. Estrogen protects his brain and heart, but if he has too much estrogen, this is what's really threatening his testosterone. Mm-hmm. So what are all the different things that run through your mind when a man has excessive estrogen? And most doctors don't even run estrogens when they're looking at a guy's testosterone, but you can see where it's important. What are the things that run through your mind of causation?
Well, the first thing that runs through my mind is that if they have a wife that's on topical hormones, that he's getting contaminated. So we spend a lot of time talking about transference from men to women and women to men. So if I have I have a few guys that do well on topical testosterone. Most of my guys are on injectable or clomiphene. So we talk a lot about transference. Then I look at them, and I've seen most of the guys that have high estrogen are usually overweight. All right. So one of the things that we'll often address is their estrogen burden. We don't spend enough time talking about the burden of hormones in our bodies. We just look at numbers on a lab slip. When I graduated from medical school, I almost had the impression that you could diagnose everything there is to know on this earth with a lab test and an x-ray. And it's just not true. So we have to get away from thinking about those numbers as being the end-all and be-all. We have to start thinking about what's going on with those numbers, and doctors tend to want to make numbers normal. So I look at their weight. A lot of times those are the guys that I'll send off to a nutritionist and say, you need to talk about, diet. You need to talk about, especially if their blood sugar is elevated, if their triglycerides are elevated, or if they're on medications for high blood pressure or high cholesterol. You need to lose some weight. Okay, that's going to be part of it. But we also want to normalize their thyroid. We want to look at iodine.
So you run thyroid levels even with testosterone. If a guy goes to a low T center, they're only going to be looking at their testosterone, maybe some estrogen, but they're not looking at the other hormonal family members.
When a patient comes to see me for low T, they sign on that I'm going to be checking their adrenals and their thyroid. And if they don't want me to do that, then they're going to go somewhere else because I'm not going to take care of them. Because it's important for me to know those things. It's not just wasting time and doing lab tests. It tells me a lot of information because what do people expect when they come to see you? They expect results. Well, if you want results, then you have to do what I know to do. And if you don't want to do what I know to do, then you don't want me to do it. And I've actually turned people away because they said, no, I don't want to do that. I said, well, you don't need to be here then. You can go somewhere else and just get a testosterone level. But I said, if you really want to do this correctly and safely and get the maximum benefits, metabolic and life benefits from these hormones, this is how you have to do it. So I turned very few people away because I'm very convincing.
Now, more and more young men have lower levels. They have, in fact, one of the famous, when I was a hormone scholar at Tulane estrogen think tank, I remember there was a famous meeting where a guy stood up in court and screamed, none of the men in here today are the same men that their grandfather were several generations ago, meaning that their testosterone levels and their fertility levels were going down. And we know that there is an epidemic. There was an article that just came out recently that even particulate pollution, when a woman is pregnant, if she's inhaling particulate pollution, if she's in the car a lot, if it's in her home, that can ding the baby's ability to even produce testosterone as it grows up into an adult. So we're in a toxic planet that's attacking our hormones. So if we have young guys, they can't go on testosterone because it'll make them infertile.
Yep.
Right? So what are the choices of 21, 22-year-old dudes that are fatigued and getting chubby and have more estrogen and getting feminized and androgynous? What are their choices?
Well, there's two things they can do. They can use injectable or topical testosterone because it is a reversible process. So it's like a woman going on a birth control pill. If a woman went on a birth control pill and would never ovulate again, there would never be a birth control pill. Well, it's the same thing with testosterone. But we try to encourage these guys to raise their own levels of testosterone with clomiphene. And that's really the best treatment. Now, if a guy has to go on testosterone when he's ready to start a family, we take him off the testosterone and stimulate him with clomiphene, just like we would stimulate a woman who was not ovulating, who's trying to get pregnant. So they have those options. But I think part of the problem is, and you alluded to it, we used to think that low T was mumps virus or trauma, but there's so much more now. It's the environment, it's pollution. And I'm going to tell you something that's going to probably blow your mind. We're doing more cesarean sections today than ever. And these kids that are being born by section are not being colonized through the vaginal bacteria like the vaginal births are. So you wonder if a lot of these kids are having problems with gut immunity, which could affect things, whether they're I know that they're more prone to upper respiratory infections and other problems. The gut bacteria, of which you're an expert, is so critical, and it has a lot to do with how these hormones work. So if you start having a lot of autoimmunity, who knows if these things aren't affecting the production or the function of testosterone at the receptor.
That is so well said. Michael Baker, who is a scientist at the University of California at UC Davis, he's the guy that writes all the major hormone books for medical textbooks, and he's been publishing lately that a healthy gut microbial life, the microbiota, is steroidogenically active and especially produces androgens, testosterone, which contributes to gut wall immunity and overall health, but it's part of where we're getting, we don't make just testosterones only in the testes, we make them in a gut, and as the guts become less healthy, multiple rounds of antibiotics, eating animals that have been given antibiotics, etc., and that is a contributing factor. Well said, Jack.
That's absolutely true. And the gut, when you think about it, it's kind of a mind bender. I tell patients, the inside, the contents of your gut is outside of your body. And they all look at me like I'm crazy. And I said, think about that for a second. The contents in your gut never come into contact with the abdominal cavity. And that lining of the gut is so critical for that separation. And we used to think that the lining was just a lining and that, the gut was just a conduit to absorb nutrients and excrete waste. But now we know, as you well know, that it's so much more important than that. And a lot of times, these guys all have some kind of other issue, especially the younger guys. Maybe they're not celiac patients, but they might have a food allergy or a gluten sensitivity. So very often these guys will end up going down the gut pathway and having the stool testing and the gluten testing and the cross-reactive foods testing to find out what's causing their problem. We have to ask the question, why does a 25-year-old, otherwise healthy guy, why does this guy have low testosterone? No history of trauma or infection. All right. He doesn't do drugs. He has a clean life. He's exercising. He's in good shape. Why does he have low T?
All right? I love that your mind bender leads to a gender bender.
Yeah. Well, it's the same thing with women. Why do women have the symptoms that they have? They don't have a Prozac deficiency when they're 38 years old. Yes, some of them may need those things, but a lot of times it's hormonal. And more
hormones
women
run our perception of life, our mood. It's everything. It's so much a bigger job description than what we've been taught.
Yeah.
So I've got a question. So what about human chorionic gonadotrophin for young guys for testosterone? Can you chat about that a second?
Sure. You can use HCG, injectable. It works the same or in a similar way as the clomiphene does. A couple of problems with it. Number one, it's an injection. So you have to inject 3 times a week. Typically, you'll get about 6 weeks out of a bottle, and then you stop it for 2 weeks, and then you start over. So it's a 6 week, 2 week, 6 week on, 2 week off cycle. Problem is, it's gotten very, very expensive. Clomiphene is rather inexpensive. Your copay, maybe a level 3 copay, which might be $30 or $40. Now, if you get 30 pills, and you're taking 1 pill 3 times a week, that's 10 weeks for $30 or $40. Whereas you go for HCG, which is maybe give you 6 weeks, it may be $150 or $200. Okay,
I see. Got it.
And also HCG comes from human urine, and sometimes guys don't like that concept. But I mean, it's possible. I mean,
it's women the golden shower pill.
Women have no problem taking Premarin, which comes from pregnant horses. Urine. So why would you worry about taking human urine? And by the way, it comes from women, not men. So
right, from pregnant women. It's a pregnancy hormone, right?
Exactly. Men don't make it, so you're not going to get it from a guy.
So what would you want to say to women who are sitting here right now and listening to this show that you've taken your Sunday afternoon, which I really appreciate it, and our listeners appreciate it, to share your hard-earned thousands of weekends that you've sat inside hotel dry air, listening and learning all of this, and then learning how to teach it so that you really own it and become a master of that information. What would be the set protective things if a man has too much low T for him? His 400 level might not be optimal for him. If a man does go work with somebody like you and gets their T replaced and fluffed up to a better level, what are all the protective things that he's doing so the wife can say to the husband or the sister can say to the brother, you should do this, and this is why?
Well, the main thing is that he's reduced his risk of dying from a lot of major diseases, particularly cardiovascular disease. It's also going to bring him back to the type of person that he was. So a lot of times, I'll tell patients before you go to the marriage counselor, before you put somebody on SSRIs, before you go to the divorce lawyer, check the hormones, because this is the person that you married for whatever reason that you loved when you were younger. Okay, what has changed? So women, if you see a change in your husband, that he's cranky, he's not the guy he used to be, he's angry, he's distant, he goes out with his buddies, he'd rather stay at home and watch TV, he's not responding to you anymore. Think about his testosterone. Think about his cognitive function. We know that it protects the brain. Okay, we know that it helps to build muscle, which helps to keep the body fat down, which helps to reduce blood sugar and the risk of diabetes and all the attendant problems with that. I mean, think about it. Especially if he gets up at night 2 or 3 times to go to the bathroom. Now you got to start thinking about testosterone imbalances with estrogen. So if you see those things, it's not just about sex. It's about all these other problems. If your man isn't the man that he used to be, and he doesn't want to admit it, think about testosterone. Guys are now becoming much more willing to come in and say, I think I have low testosterone.
I love the way you just put that, because my mind is scrolling through so many patient examples. Mm-hmm. That is so right on. I had a couple that have now been married about 45 years, but when I first saw them, they were married 35 years, and they had just become distant, but they owned a business together, so there was a lot of chafing and anxiety because they were distant, but they were working together all day long, and it turned out that a lot of it was hormonal. And when both of them, the family that balances their hormones together stays together. It's not. That's right. It's a truthful saying. When they both worked on it, I got this $100 bouquet of flowers. I love getting, by the way, to anyone out there, $100 bouquet of flowers. And they sent me this with a thank you note that their life was given back and it was better even than it had been in their romantic courting stage. So what you're saying now, that's just so big and so real.
And I see it all the time, and I see the frustration in people that, they're doctors, they're so frustrated with the conventional approach because, they've tried so many different doctors, they've tried so many different treatments, and nothing has worked, and the doctor says, well, there's nothing wrong with you. And I say, really? Because the doctor couldn't come up with the answer, that means that there's nothing wrong with you, that you must be crazy. So you need to go to a psychiatrist and sit on the couch for an hour and pay out of pocket and get a prescription for 2 or 3 different kinds of medications. And it's just crazy the way we're approaching these problems. And I wish that we would teach more of this in medical school. I've offered, but so far I haven't gotten any takers.
So a lot of times when a doctor says there's nothing wrong with you or there's nothing left to be done for you, what it means is they don't know what's wrong with you, or they don't know what's left to be done for you. And often now in your mind, in your thought process, in your tool bag, you should at least be open to the concept that it might be that you have unhealthy hormones that are masking your perception of your world and your experience of living inside your bodysuit.
I've had so many patients say, you mean I'm not crazy? It's like, no, you're not crazy. There's something going on here. And we're not taught these relationships. We're taught to think in a very linear fashion. And we have to start looking at the interactions of all of these different endocrine systems and how they work. I mean, the human body is complicated for a reason, okay? Because nobody on this earth is smart enough to make that kind of human body. But there are complex interactions, and I think it's probably meant to keep us busy for a long time, and I think it will, because we keep finding out new things about the human body that we never knew. Certainly not what I was taught in medical school 40-odd years ago, and I said I wasn't going to mention that, but I think it's important. So we've been around a long time, and things have changed so much, and they continue to change. And if you're not part of that change, train's out of the station. You're standing on the dock there.
Now, I don't want to bash docs. This is not a doctor bashing show, and many of my guests on the show are doctors. And, but I do want to just share this one experience, and I want you to comment on it.
Okay.
So I'm dating, and I'm on Match.com, and some guy reaches out to me, and we start chatting, and it turns out that he's a urologist that just retired from his private urology practice in another state and has moved here to head all of the low T centers that are in this state and several contiguous states. And that's what he's doing. And when we go out for dinner, he confesses to me once we start talking, and he Googles me on the web, that he doesn't know anything about testosterone, and he's thinking we should open these clinics together, or maybe we should go off and do other things. And I start realizing how much he had not done any of that in practice, and it wasn't what he was about. And so when and yet he was running and training the docs at the low T centers. So it's very easy to get wrong bad medicine.
Sure. It's like the death leading the blind, It's unbelievable. One of the things that is so important that doctors just simply don't tell their patients about these hormones, especially with the topical, is what we talked about earlier, transference. Now, for the ladies out there, okay, you go to the gym, or you go to a public gym, you need to wipe down every piece of equipment that you touch. You need to wear long pants. You need to wear, shirts with sleeves, and lifting gloves, because there's always some knucklehead in the men's locker room that's slathering on the androgel. You know the guys I'm talking about. They're the ones that are strutting around like peacocks, posing in front of the mirror and slamming the weights, okay? And I see more women that come in that have high testosterone levels on salivary testing. Their husband's not taking anything. They either have a personal trainer, a male personal trainer, or they're going to a public gym. Okay, so you need to cover up and you need to wipe down the equipment, because that's one of the biggest unrecognized sources of transference of testosterone to women. Okay?
That is a great pearl. Wow. You know, I always wipe my hands when I leave the gym, which is my second home, every single day because of all the germs. But I have never thought of transference of testosterone from guys in the gym using it.
Yeah.
Wow.
The other way to transfer it is the husband is putting androgel on. Now, the urologist tells them to rub it into their shoulder, right? How do you rub it into the shoulder? With the palm of your hand, okay? So now what do? You go over and you turn the faucet on. Now it's on the faucet handle. Then you grab the soap and you wash your hands off. You've got it off your hands. You turn the faucet off. Now it's back on your hand. Then you go over and you wipe your hand on the towel. Now it's on the towel. Okay, or like one of my patients' husband did, he didn't wash his hands. So everything that man touched from the time he put his gel on until the time he walked out of the house, everything he touched had testosterone on it. The banister going down the stairs, the cabinet where he opened up to get his coffee mug, the handle on the coffee pot, the door handle walking out the door, the steering wheel in the car. Okay, you've got to teach people how to put these hormones on correctly and how to avoid transference. That's a huge problem.
How come you like, and why is it that the male body seems to like injectables better than topicals? Women use topicals a lot more, but I find men often don't get a great response from topical.
That's exactly true. And that's why I stopped using the topical, because the dosing is so hard to get right. Because for women, you know, and it's the same problem in women with libido. The guys that I was using topicals on called me up and said, I just don't feel any different, okay? And I tried everything, in myself included, from 2 milligrams up to 75 milligrams a day, okay? And I never saw a really good response. But when I put these guys on twice a week injectable, small doses twice a week, they spend more time in the physiologic range, that optimal range in their body. But the thing is that topical gets delivered to the tissues, where the injectable is more circulated through the vascular system, and I think it might bloodstream. Yeah, I think it might just have a better effect. You know, I just get much better response to the injectable testosterone if they do small doses twice a week.
Now, if the man can't do small doses, what do you think about putting the cream on their anal mucosa so you're getting transmucosal delivery?
That's above my pay grade when you start talking like that, Lindsay.
Okay, because I know some of my colleagues recommend that. That's why I'm asking that. Okay.
Yeah, that's a hard sell for guys, I think.
Because women do it. Women have vaginal application, but men is a hard sell for guys. Okay.
Yeah, but truthfully, I mean, when we talk about the injectable,
I actually had a patient who couldn't handle thyroid, and one of his docs had put him on thyroid cream on the anal area, so that it is an area where you can have delivery. But I imagine much more men are uncomfortable with it. But it is an option.
The only problem with doing that is you often wonder about variability of absorption. You know, let's say that the guy puts the cream on there, and then maybe a half an hour later he goes into the bathroom and he has a bowel movement. Okay, now he's wiped most of the cream off, so you might get some inconsistency. Where the injectable is twice a week, and you get every drop that you inject. So there's much more consistency. Even with the Topiclick in women, the applicator for their cream, I always worry about the variability. So we teach them how to click it so that they get more consistent dosing.
So how come women don't have very tiny little amounts of hormone delivered through injection versus the topical and the patch and this and that? Why
That's
is that?
A good question. I think because topical works so well in women, and you know, you can use an intravaginal application, and that works for women really well. But for guys, it's you know, we're not giving them multiple hormones. We're just
definitely
giving them
a difference between men and women here. The way you get your hormone in.
Women are getting estrogen, progesterone, testosterone. Men are getting testosterone. we're not giving them estrogen. We're not giving them progesterone necessarily. I mean, I've got some guys on progesterone. There's an indication for that. But.
Right. We can go. We'll talk on that for another show. But I want to tell you that this has been such usable and fantastic and important information. It's life-saving. Life-saving. Mm-hmm. If your husband and the men you care about have higher normal levels of testosterone, they're going to live longer from all-cause potential premature causality of death. They're going to have healthier mitochondria, so better energy. They're going to have healthier blood lipids, so better heart health. They're going to have less risk of type 2 diabetes. They're going to have thicker hippocampus where their memories live. So they're going to remember all the stuff better that you shared together and have less risk of dementia, so you have more time to make more memories.
And they're going to be nicer people.
That's
because
a big
nothing frustrates a guy more when he can't do what he knows he can do, and he starts getting cranky and ornery. Like the grumpy old men. Okay, that we become better people. We're much happier. So it's really important.
Hormone health, balanced hormone health equals better people, happier families, more peaceful planet. It really does start with a hormone a day.
Yeah, there's a lot of good information. There's a lot of good information on my website. There's some YouTube videos.
Oh, yeah, give your website, would you please?
Yeah. Sure, it's NashvilleHormone.com. Nashville, NashvilleHormone, HORMONE, NashvilleHormone.com. There's a lot of good information on there. And, I see people from all around the country, so it's not out of the realm of possibility for somebody to come and visit. Nashville's a great place to visit.
I've sent you some of my patients.
Oh, I know you have, and vice versa.
Yes, you have. Yeah.
Mm-hmm. So we have a nice pipeline between Austin and Nashville.
We do.
But you come to Nashville, you go to Austin, you make it a business and a pleasure trip. So you're going there for a medical reason, but then you can go to the honky tonks, you can go to the Grand Ole Opry, you can go wherever and have a great old time.
It is always a joy talking to you, and I'm going to see you really soon, and I'm even going to stay there and cook you some of Dr. Lindsay's meals.
I'm looking forward to that.
Thank you so much for sharing this Sunday, and thank you for all this life-saving information. Is there any one final thing you want to say, Dr. Jack?
Yes. Thank you for asking me to do these. I love teaching, and I love to get this information out there, and I love you.
Love you back. Ditto.
Right.
Bye. Blessings. Bye.